lecture. Today we are going to started the second part of this lecture. So today we've started with the complications of blood transfusion reactions, and we've for ease of understanding, there are so many methods of classifying blood transfusion reaction, but to clearly simplify it for our understanding, we classified it broadly based on acute, time, and delayed, and also whether it's febrile or non-febrile. So that was the first part of the lecture we did. We classified it into acute and delayed transfusion reactions, and we were still on acute transfusion reaction, but we have handled the acute hemolytic transfusion reaction. So today we are going to look at another type of acute transfusion reaction, which is febrile non-hemolytic transfusion reaction. So by definition, it is mainly the most frequently reported reaction. Okay. And the incidents have since reduced with the practice of leukoreduction, what we call leukoreduction, reducing the amount of white blood cells in blood products. Since the practice started, the data on cases for febrile non-hemolytic transfusion reactions have reduced to some extent, but it is still more common than any other transfusion reaction, especially it occurs with the platelet transfusion reactions. Okay, before that leukoreduction, we have as many as 1/3 of platelet reactions causing this febrile non-hemolytic transfusion reaction. So it is unexplained increase in temperature of 1 degree centigrade following blood transfusion. Okay, you observe that the patient that is being transfused has an increase in blood temperature, in body temperature by 1 degree centigrade. So that is the clinical definition for febrile non-hemolytic transfusion reaction. So what are the causes? It is caused by increased pyrogenic substances like the TNF-A, the interleukins, okay, which we have in white blood cells. They are the substances that are implicated in febrile non-hemolytic transfusion reaction. Okay, so these cytokines, these substances that are coming from the white blood cells, they can be produced before transfusion. Take, for example, platelets. If someone should be transfused with platelets, okay, platelets are normally stored at room temperature, okay, with constant agitation. So, but at that condition, the white blood cells any white blood cell remaining in such products, okay, gets agitated and start to release some of these pyrogenic substances, so that subsequent to transfusion of such plate products to a recipient, it will initiate a febrile non-hemolytic transfusion reactions. Or it can also occur, the cytokines may be produced after transfusion. Take, for example, red blood cells. The storage of red blood cells in blood banks, that is in refrigerated temperature, allows the white blood cells to be in a state of calmness. Okay, they are not agitated, they are cool, they are okay, they are not releasing any pyrogenic substances in that condition. Okay, so but sometimes after transfusion, okay, the recipient's anti-HLA antibodies can attack donor white blood cells. okay? Because as it is now, during normal blood donation, okay, if you are trying to transfuse someone with red blood cells, normally in our setting, we match the red cells antigens mostly. Okay, we match the red cell antigen mostly. We don't really match the white blood cells antigens. So because of that, there may be some incompatibility in white cell antigens or antibodies of the donor and the recipients. So that when we transfuse red blood cells, remember white cells can still be part of that transfusion. So when we transfuse these red blood cells, the white cells can initiate some reactions. It can be initiate some reactions releasing these pyogenic substances that can induce fever. Okay, so we say it's more common with red blood cell transfusion, that is post transfusion cytokine generation, but pre-transfusion cytokine generation occurs mostly with a platelet transfusion. What are the signs or symptoms of febrile non-hemolytic transfusion reaction? They include 1, transient fever and chills, plus or minus rigors, occurring up to 2 hours after, can occur during or up to 2 hours after the transfusion. You observe that the patient or the recipient comes down with fever and chills, sometimes with rigors, okay? But the symptoms tend to occur later in transfusion, unlike the acute transfusion reaction where there is rapid onset of so many complications. If very early, be suspicious of transfusion-related sepsis, okay? Note that chills may be first, fever may be delayed up to 1 or more after transfusion in up to 10% of the cases. Okay, there are variant versions, that is variant presentations of this fever in patients that comes down with febrile hemolytic transfusion reaction. There are various versions, some come early, some come delayed, and all that. Okay, so it needs to be differentiated from acute hemolytic transfusion reaction. Okay, from acute hemolytic reaction. We say that most acute hemolytic reactions present with fever and chills alone. Okay. Okay. It is impossible to distinguish early acute hemolytic transfusion reaction from febrile non-hemolytic transfusion reaction clinically, though most fever in transfusion will not be acute hemolytic transfusion reaction. So we need to really define the condition of the fever. We really need to differentiate acute hemolytic transfusion reaction from febrile hemolytic non-transfusion reaction as per fever. Okay, although acute hemolytic transfusion reaction also presents with, as we saw earlier in our first lecture, with so many complications. Okay, so many other complications. Okay, so also we need to differentiate this hemolytic febrile non-hemolytic transfusion reaction from transfusion-related sepsis. We are still going to see sepsis. So especially sepsis from platelet transfusions. Okay, they will still cause fever. We'll still look at sepsis as we go on. So laboratory findings in febrile non-hemolytic transfusion reaction is none. Okay, none. Okay, may not see, there may not be any laboratory findings because some of the organs are not mostly affected like we have in acute hemolytic transfusion reaction, but they can be prevented. We can prevent this febrile non-hemolytic transfusion reaction during red blood cell transfusion. As you can see with platelet transfusion, the cytokines are being formed while we store the platelets, because platelets has to be stored at room temperature with constant agitation. So that condition of storing platelets enhances white cell agitation and release of some of the pyogenic substances. Okay, but so to prevent it may be leukoreduction completely in platelets, which the feasibility we cannot be assured of, but we can prevent febrile hemolytic, non-hemolytic transfusion reaction with red blood cells transfusion. Okay, because most are due to post-transfusion white blood cell production of pyogenic cytokines. So leukoreduction works extremely well to prevent the vast majority of these reactions. So for red blood cell transfusion reaction, we can actually reduce the occurrence of febrile non-hemolytic transfusion reactions by carrying out leukoreduction, reducing the amount of white blood cells that get transfused along as we give red blood cells. Okay, we can also prevent febrile non-hemolytic transfusion reaction during platelet transfusion. As we said earlier, most are due to pre-transfusion cytokine production by white blood cell. Pre-transfusion, before we transfuse the platelets, the cytokines are already formed inside the bag. So pre-storage leukoreduction is best. Before we store platelets, before we keep platelets, we need to reduce the white cells contents. Although we can still see some reactions, 0.1 to 1% of platelet transfusions. So exception is soluble CD40 ligand is platelet derived and causes fever. So leukoreduction won't prevent this type of reaction from soluble CD4 ligands. So we have another reaction that is also an acute transfusion reaction. Remember, we are still dealing with acute transfusion reactions. We've dealt with acute hemolytic transfusion reaction. We just finished febrile non-hemolytic transfusion reaction. So transfusion-related sepsis, that is bacterial contamination of blood or blood products, is also an acute transfusion. It's present in form of acute transfusion reaction. So it is the bacterial contamination, okay, is the number one infectious risk from transfusion, much more common than viruses, bacterial infection, contamination of blood products. Okay, is the number one risk from transfusion. Okay, it's much more common than viruses. 1 in 3,000 platelets units are contaminated. Most contaminated products that cause reaction are closer to their expiration dates. Okay, this gives bacteria time to proliferate and enter the log phase. And remember, before we collect these blood products, okay, we must use needle and puncture the skin. So that's action of piercing the skin to collect the products and also contribute to contamination of that of the blood product. Okay, and storing this product for quite a number of days can also give the bacteria the room to multiply inside this blood. Okay, pathophysiology. Platelets are contaminated, okay, by skin contaminants from the collection process. Okay, because how many persons do we have to bleed to get enough platelets? Up to 20 donors, okay, can harbor organisms. So we advise using diversion pouches that accept the first 30 to 50 mils or so of collected blood in a donation are meant to harvest potentially contaminated skin block. So diversion pouches can help eliminate this problem to some extent. Red blood cells are more commonly contaminated by an organism growing in the donor's blood, often asymptomatic. At the time of screening the donor, we may not be able to get it because at that time it's asymptomatic. The donor is asymptomatic. The most common organism is Yersinia enterocolacea. Is the most common organism that contaminates blood products. Okay, by 2021, breakdown of products and organisms that contaminates them. Okay, has Solaren treated apheresis platelets being contaminated by these organisms, Bacillus species, okay, Staphylococcus saprophyticus, okay, apheresis platelets, okay, this is treated platelets, apheresis platelets being contaminated by Staphylococcus aureus, okay, apheresis platelets split units, okay, being contaminated by Escherichia coli and apheresis platelets, okay, Escherichia coli, apheresis platelets, Corynebacterium striatum. So different organisms contaminating some of the blood products that we use. So bacterial contamination by implicated organism, okay. So for the fiscal year from 2017 to 2021, okay, these organisms were reported to have contaminated blood products, okay. As you can see in this table for 2027, there are a total of 5 organisms for contaminating blood products. Okay, so from this table now we can see most of the organisms that contaminates the blood products. So from 2020, 2017, 2018, 19 up to 2021. Okay, so the most common organism implicated Staphylococcus aureus and Clostridium perfringens are the most common organisms for these 5 physical years. Contamination by implicated blood products, okay, for red blood cells, pooled platelets, apheresis platelets, and plasma, okay. You can see the products that was more contaminated and mostly these apheresis platelets. Most contaminated products, the apheresis platelets, okay. And also in 2021, you can also see that apheresis platelets are being mostly contaminated blood products, okay. Organism identified depends on the products. For red blood cells, the organisms that are mostly contaminate red blood cells include gram-negative rods, okay, because they like growing in the cold temperature, okay. So we have Yersinia enterocolacea, okay. We have all these organisms, Pseudomonas. We also have gram-positive cocci, okay. All these organisms have been implicated in red blood cell contamination. Then in platelets, majority of the organisms that contaminate platelets are gram-positive cocci, that is skin contaminants, okay, including the ones we mentioned for red blood cells. Majority result in only mild reaction or none. They also have gram-negative that also contaminates platelets. So plasma products are uncommonly contaminated. There are only few reports involving water bath contamination with Pseudomonas species. So what are the signs and symptoms of febrile non-hemolytic transfusion reactions? So there is a rapid onset of high fever, often greater than 4 Fahrenheit or 2 degrees centigrade, with rigors through shaking, chills, with rigidity, with rigors, shaking. We have abdominal cramping, nausea, and also vomiting, hypotension and shock, and disseminated intravascular coagulation. These are some of the signs and symptoms of febrile non-hemolytic transfusion reactions. So we need also, as you read along the febrile non-hemolytic transfusion reaction, diagnosis of febrile non-hemolytic transfusion, or in real practice, we really have to differentiate acute hemolytic transfusion reaction, anaphylactic transfusion reactions. That reaction we still look at one by one. Then from febrile non-hemolytic transfusion reaction, sepsis from non-transfusion source. So we really need to differentiate the fever from each one of this. Okay, like the acute hemolytic transfusion reaction, as always, severe, okay, severe septic reactions, okay, however, usually are more acute and dramatic in presentation, just like we said earlier during the first lecture. Okay, the onset is very, very dramatic for acute hemolytic transfusion because of the cause, which may be ABO incompatibility. So we're going to see other transfusion reactions. So in differentiating the fever or the clinical presentation, okay, of contamination sepsis, okay, we need to differentiate it from acute hemolytic transfusion reaction, anaphylactic transfusion reaction, febrile non-hemolytic transfusion reaction. We say that here the fever in febrile non-hemolytic reaction is milder. Okay, okay. Then sepsis from non-transfusion source, like infected lines and all that. So we really need to differentiate the fever occurring in sepsis, okay, due to contaminated blood products, from fever occurring as a result of other acute transfusion reactions. So how do we diagnose reactions coming from blood product contamination? Number one, when you look at the red blood cell product, you can see the coloration is deviates from normal. It's darker when a red cell that is being stored for a very long time, when you pick it up, you notice that it's darker or almost purple. Okay, so there's bacteria feeding inside that red blood cells. So we also observe hemoglobinemia, hemoglobinuria, but it's not as a result of antibody reaction. That is negative. Okay, that is negative. Okay, gram stain positive if only half to two-thirds of proven cases. Okay, gram stains are the implicating the causing organisms. When we stain the blood, you observe that we can identify some gram positive organisms. Okay, but the source of the gram stain and culture is very important. Okay, the source, is it from the bag? Is it from the line of the blood bag? Is it from the patient? Okay, so avoid culturing or staining a segment unless if nothing else is available. Remember also to culture associated IV fluids and consider that an indwelling IV catheter may be a source of contamination. Culture is proof of the fact that it is an organism that contaminates the blood product, but we must culture from the bag, we must culture from the line, and also the recipients of the blood products must also be cultured. So identification of the same organism in the bag, in the line, and in the recipients confirms that it's as a result of contamination, sepsis from contaminated blood products. So this condition can be managed by antibiotics given intravenously, pressure, respiratory, general support as needed. Then the blood product, other blood product from the same donation line has to be quarantined or discarded. Okay, so it can be prevented by careful donor history documentation. Careful donor history documentation. And that is why it's mostly advocates that we use relative donors and not commercial donors, because a lot of information may not be released at the point of donation, at the point of enrollment for the donation. Then we also ensure proper phlebotomy technique, use of diversion pouches, very mandatory, platelets, so as to remove those first blood flow that may contain some bacteria or some skin contaminants. Okay, strict attention to possible site contamination. Then leukoreduction filters may decrease risk of some of these organisms. Routine detection of platelet contamination, then pathogen reduction also should be practiced. So another acute transfusion reaction that we have, remember we've treated acute, we are still on acute transfusion reaction. We have treated acute hemolytic transfusion reaction. We have treated febrile non-hemolytic transfusion reaction. We have treated reaction due to contamination of blood products, sepsis. We have transfusion-related acute lung injury, which we call TRALI. So by definition, TRALI is a syndrome of acute hypoxia as a result of non-cardiogenic pulmonary edema that follows transfusion, or all new acute lung injury less than 6 hours after transfusion. A patient have never been presented with acute lung injury except after transfusion. 6 hours post transfusion, a patient presents with acute lung injury. And the high chances are that it may be as a result of the transfusion. TRALI, transfusion-related acute lung injury. So it's a syndrome of acute hypoxia as a result of non-cardiogenic pulmonary edema that follows transfusion. Okay. So it's lack of other risk factors for pulmonary edema. There are no other reasons why the recipient will come down with such condition. Okay, no pre-existing acute lung injury prior to that transfusion. Usually also it occurs with fever, chills, transient hypertension, then hypotension. Platelets, plasma transfusion most often are implicated in TRALI, but it can also occur with red blood cells and whole blood cells. So the incidence varies widely, 1 in 120 to 190,000 of plasma containing transfusions. Clinical differential diagnosis. The common symptoms include fever, chills, hyperden, hypotension, almost with plasma-rich products, as we said. Clinical differential diagnosis has to be differentiated from acute respiratory distress syndrome. TRALI may look exactly like acute respiratory distress syndrome, but TRALI usually resolves in 24 to 48 hours if managed. It also needs also to differentiate TRALI from transfusion-associated circulatory overload. Okay, they may be identical clinically, complete with a wet chest X-ray, but TRALI is usually associated with fever, unlike TACO that does not respond to diuretics. So these are some of the differential diagnostics. Acute pulmonary and myocardial disorder, we need to also differentiate TRALI from that, and we say that TRALI are all new acute lung injury that sets up 6 hours post transfusion. So TRALI fatalities by implicated blood products. Okay, so by blood products, we can also see that They didn't give the total, but we can see as at 2021, okay, red blood cells implicated with TRALI, apheresis, multiple products, fresh frozen plasma, okay. So red blood cells mostly implicated, TRALI was mostly implicated with red blood cell transfusion, okay. And you can see as the year goes by, the reduction in TRALI occurrence. So what is the pathophysiology of TRALI? Transfusion-associated acute lung injury. How does it occur? So two currently accepted pathways are closely related. We have the neutrophils in the pathophysiology of TRALI. That's neutrophils are implicated in the pathophysiology of TRALI. Okay, we have the donor antibody pathway. The donor antibody pathway for TRALI. So here, anti-HLA or anti-neutrophil antibodies from the donor bind to antigens on the recipient's neutrophil. I've emphasized earlier that during blood donation or blood products, blood transfusion or blood product transfusions, especially as it concerns our setting, that we majorly match red blood cell antigen. Okay, most of the times we don't match for white blood cell antigen during normal blood transfusion or plasma transfusion or platelet transfusion. We don't usually match for the white blood cells. So antibodies by white blood cells, white blood cell antigen antibodies, okay, can elicit reactions, and that is why after transfusion some of these complications occur. So we are saying for TRALI there's pathway to it, and neutrophils are implicated in the cause of this complication. Okay, that anti-human leukocyte antigen, human leukocyte antigens, okay, from or anti-neutrophil antibody from the donor binds to antigen on the recipient's neutrophil. Okay, here the antibody neutrophil complexes deposit in pulmonary vasculature and activates the polymorphonuclear bactericidal responses. Okay, with the secretion of toxic oxygen radicals and bactericidal enzymes. When white blood cells are being triggered, when they are being activated, when they are being aggravated, they are the soldiers of the body. So anything that triggers them will cause them to release their arsenals they use to fight infections. Okay, so because of this antigen antibody reaction, they release their arsenals. Okay, but in this scenario now, there's no organisms to be fight, so they attack the endothelial linings of the lungs. So secretion of toxic oxygen radicals and bactericidal enzymes by these white cells leads to damage of pulmonary endothelial cells lining the capillaries, with resultant leakage of fluid into the alveolar spaces. That is what leads to the edema we notice in TRALI. So as these white blood cells are being aggravated, they release their cytokines and cause disruption or attack the endothelial lining of the pulmonary vasculature. Okay, and when they are being attacked, that's creating uh, uh, leakages, fluids escaping from the into the alveolar spaces. So this mechanism may also occur with recipient antibody, either with the recipient antigen or the recipient antibody against donor white cell. But this is less common. Okay, the antigen is more common than the antibodies. So this is just a diagram demonstrating, showing what we have just said. Okay, this is the blood components containing these white cell antibodies in the donor interacts with cognate antigen on recipient's white blood cells. So these antibodies interact with the antigens on the recipient's white cell, causing aggregations in the pulmonary microvasculature and activation of the white blood cells. These white blood cells that are resting in this position, you can see the antibodies attacking the white blood cell antigens, and when that happens, these white cells are being activated, and when white cells are activated, that means they release their defense mechanism to fight against anything that is activating the body. So here they release the activated white cells, produce and release reactive oxygen radicals and enzymes, okay, which in the absence of a microorganism target instead cause damage to the pulmonary endothelium. So in the absence of any microorganism for them to fight, they attack the pulmonary endothelium. You can see it here. Okay, damage to the pulmonary endothelium allows the leakage of fluid. You can see this arrow, the leakage of fluid into the pulmonary space that causes the clinical symptom of respiratory distress in TRALI. So this is the mechanism of the pathophysiology for TRALI, transfusion associated acute lung injury. So this the same pathophysiology we just described. Some persons view it as not being as straightforward as we first described. Okay, that's how the two event pathway was born. So they try to explain the pathophysiology of TRALI in two steps. The first steps, they are advocate that pre-transfusion condition that activates lung endothelial cells and prime the white blood cells. Okay, for example, that sepsis in the donor. Okay, massive transfusion, maybe it's a recipient that there are some conditions that have primed already these white cells, maybe in the donor or in the recipient. The activation puts the patient in a state where an additional push could start the process of so just like we were saying before the interruption came in, the pathophysiology we have explained can also be broken down into two steps as described by some persons. Okay, so the first is that the recipients have been primed in such a way that any further push can activate the white cells to begin to release their cytokines. Then the second event, so that with any transfusion of stored blood products, even stored blood products accumulate substances called biologic response modifiers that can prime or activate destructive neutrophils. Okay, so either biologic response modifiers or antibodies mentioned in the first hypothesis, there are two hypotheses, may induce capillary damage by activating the white blood cells. Okay, by activating the prime white blood cell to secrete toxic substances. So the major underlying pathophysiology of TRALI is that there are conditions, there are situations that led to white blood cells being activated, being primed, okay, and once they are activated, they become aggravated and they release their oxygen radicals, okay, that can damage the capillary lining of the pulmonary vasculature, okay, leading to escape of fluid into the alveolar spaces and the resultant respiratory distress that the recipient comes down with. So this the two event pathway models, almost the same thing as we said earlier. So diagnosis. So for the diagnosis of TRALI, majorly by bilateral chest X-ray infiltrate, oxygen saturation less than 90%. So it involves a radiological examination of the lungs. So there are no evidence of volume overload. Okay, no evidence of volume overload, but although we have respiratory distress, but it's not as a result of volume overload. That is, when you look at the neck, there are no jugular venous distension on the neck region. Okay, normal wedge pressure, normal BNP levels. Okay, so lab findings may include demonstration of anti-HLA antibodies or anti-neutrophil antibodies and possibly increased biological response modifiers in the bag. So these are some of the things that can be done if we want to investigate TRALI. It is a clinical and radiological diagnosis, okay? Laboratory investigation, quite complex, will be very, very tedious. It's majorly a clinical and radiographic diagnosis. Confirming the presence of donor antibody may take days or weeks. So most times it's being diagnosed by the clinical examination and radiographic examination. So treatment is mainly respiratory support. Mortality reported between 5 to 25 and 80% recover quickly. So it can be prevented. Implicated donors with antibodies should be deferred from donation. That is why most of the times male donors are preferred to female donors, because sometimes women that have given birth have a lot of antibodies in their systems. So sometimes male donors are preferred. Use of male plasma has been shown to decrease the risk of TRALI. Females have more anti-HLA and anti-neutrophil antibody because of pregnancy. Testing parous female platelet donor for anti-HLA neutrophil antibodies and differing those who have antibodies will also serve as a means of preventing TRALI. Okay. So another acute transfusion reaction we are going to look at is acute reaction presenting without fever. All this while, acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction due to blood product contamination, TRALI are present with fever. Then we have acute reaction presenting without fever. Here we have allergic transfusion reactions. They are the most common adverse reaction to transfusion therapy. Different forms are recognized with regard to severity of the reaction. We have mild, moderate, and severe. So mild allergic reaction, we have urticaria, okay, transfusion reaction. The incidence is 1 to 3% of transfusion of plasma or platelets and 0.1 to 0.3% of red blood cell. Clinical presentation include localized hives, angioedemas, that is severe swelling around the eyes and lips, mild respiratory symptoms, and laryngeal edema. Okay, it's mostly IgE mediated. Okay, hypersensitivity to transfused plasma proteins, not usually a specific identifiable allergy. Okay, so mast cell secretion of histamine and resultant cytokine and other mediators of allergic reaction. So it's usually IgE mediated allergic reaction. So treatment clinicians talk about that better. So moderate allergic anaphylactoid transfusion reaction. Some allergic reaction fall between the two classes of mild and severe. So they are classified into moderate transfusion reactions, and they may present with upper and lower airway obstructions, okay, with cutaneous manifestation, upper and lower airways obstructions. Okay. So severe allergic transfusions, they are allergic transfusion that result in shock and hypotension. They're seen in those with undetectable IgA levels. Okay. Some persons with very low IgA level come down with such transfusion reactions. Other causes include haptoglobin deficiency, latex, drugs, food in donors can lead to severe reactions sometimes. Okay. The incidence is 1 in 20,000 to 1 in 50,000 transfusions. The clinical presentation is anaphylactic shock, very early in transfusion reaction, respiratory symptoms with acute hypotension, GI complication. We also have skin finding of urticaria, angioedema, and generalized pruritus. So these are some of the clinical presentation for severe allergic reactions, present mostly in persons with IgA deficiency or very low IgA. Diagnosis is to check for pre-transfusion sample for serum IgA levels. Those with very low undetectable IgA levels should be tested for anti-IgA. Okay, so differential diagnosis, we also have to differentiate it from acute hemolytic transfusion reaction, which is typically febrile. Most acute hemolytic transfusion reactions don't present this early. Septic transfusion reaction, we have to also differentiate it from septic transfusion reaction. High fevers and lack of skin finding in septic reaction may be the only way to distinguish early. Acute hypotensive reaction. These reactions have hypotension only without respiratory or skin finding. Treatment is with epinephrine and bronchodilators. So for allergic transfusion reactions, we need to carefully differentiate it from acute hemolytic transfusion reaction, which is typically febrile. Okay, septic transfusion reaction is very high fevers. Okay, doesn't have skin findings. Okay, acute hypotensive reaction is okay, hypotension only without skin finding, but in allergic reactions we have skin findings. So prevention is IgA deficient product traditionally given for those with demonstrated antibodies. Okay, so these patients lack or have very low IgA. Okay, so if it's very good to give them IgA deficient products. Okay, IgA deficient options. You wash cellular products. Okay, if you can wash it. Autologous units. Okay, so these are some of the ways that we can prevent these severe allergic reactions, okay, from occurring by washing the cellular product, okay, or products from IgA deficient donor should be given, okay, or autologous units should be used. So for patients with no demonstrable IgA deficiency, you use wash cellular products and prepare and use autologous units instead. So we have acute hypotensive reactions. By CDC definition, it is greater than 30 millimeter mercury drop in systolic blood pressure with diastolic pressure less than 8. It occurs less than 15 minutes after the start of transfusion and resolves within 10 minutes after transfusion has stopped. Okay, these reactions are similar to severe allergic reactions, but only have severe hypotension with no skin symptoms, no GI complaints, and no respiratory issues. Okay. Pathophysiology: patients taking angiotensin converting enzyme inhibitors. Okay. There is a rapid onset of flushing and hypotension in transfused patients who are on ACEs, okay, probably because by accumulation of increased bradykinins or metabolites generated during storage, okay, and then the ACE inhibitor prevents full metabolism of bradykinin, okay. It actually stops at the potent metabolite with a longer half-life, okay. So this bradykinin or their metabolized causes marked transient hypotension. So mostly in patients that are on ACEs. Patients receiving blood through negatively charged filters can also um, come down with acute hypotensive reactions. Okay. So the diagnosis is clearly that of exclusion. You need to rule out acute hemolytic transfusion reaction, severe allergic reaction due to blood product contamination is that of exclusion. When you have excluded other reactions, still the patient is experiencing some clinical presentation, then may decide to stop the transfusion, give fluids, consider epinephrine if not resolved promptly. Okay. Prophylactic measure may not be necessary. Avoid bedside leukoreduction filter and stop ACE before therapeutic apheresis procedures. So we have also another acute transfusion reaction, that is transfusion-associated circulatory overload. By definition, it is acute onset of congestive heart failure as a result of blood transfusion. Acute onset of congestive heart failure as a result of blood transfusion. Okay, we have dyspnea, that is the presentations. Okay, dyspnea, bilateral rise with hypoxia, systolic hypotension, okay, tachycardia, jugular vein distension. Okay, when you look at the patient, the recipient's neck region, you can see the jugular vein distended. Okay, it's usually a febrile, X-ray with bilateral basilar infiltrate. Patient with pre-existing congestive heart failure, okay, very old patients can happen in them. Patients with renal failure, TACO can also manifest in them. Patients with chronic anemias like sickle cell disease due to compensation for anemia with increased plasma volume. So these patients can come down with TACO as a result of patients with pre-existing congestive heart failure can come down with TACO. Very old patients can experience TACO during transfusion. Patients with renal failure, patients that have chronic anemia, and this necessitates, because of the chronic anemia they have, like in sickle cell patients, they are transfused often. Okay, so that's regular transfusion can also result in circulatory overload in such patients. So TACO fatalities are the fiscal year 2012 to 2021. Okay, we can see also from 2020 it starts rising again. Okay, so like we said in our initial lectures, that transfusion still harm. Okay, so diagnosis of TACO we observe hypoxia, less than 90% saturation on room temperature, on room air, okay, bilateral chest x-ray infiltrates, reactions occurring within 6 hours of transfusion. But how do we differentiate TACO from TRALI? We need to do that. Okay, all of them present with respiratory distress. Okay, but TRALI response to diuretics, positional changes in TACO. Okay, as fever in TRALI. In TACO, we don't have fever. Okay, response to diuretics, okay, and positional changes. That is in TACO, if the patient is given diuretics, it responds positively. But in TRALI, the patient does not respond to diuretics. And also have fever in TRALI and no fever in TACO. Then laboratory finding, you find elevated BMPs, they suggest TACO. Okay. Finding also have, when we see anti-HLA, we know we are talking about TRALI. Okay. So treatment for TACO is to stop the transfusion, evaluate and sit up the patient, give supplemental oxygen, diuretics to decrease volume, blood volume. In severe cases, therapeutic phlebotomy may be indicated. So for prevention in at-risk patients, control the infusion rates, split unit into aliquots when possible. Okay, shouldn't be given at a stretch. Consider lower volume units or volume reduction of certain products. So comparison of TRALI and TACO. This is a comparison. Patient characteristics in TRALI, we say that it's more common in hematology and surgical patients. TACO is most common in aged patients that are above 70 years, but it can also occur in any age. The implicated blood component for TRALI is usually plasma or platelets. For TACO, any blood products can cause it. The onset up to 6 hours from transfusion, usually within 2 hours for TRALI, but for TACO within 6 hours of transfusion, TACO sets in. So oxygen saturation in TRALI is reduced. It's also reduced in TACO. The blood pressure in TRALI is often low. In TACO, the blood pressure is high. Jugular venous pressure is normal or low for TRALI, but for TACO, it's elevated. The temperature often raised in TRALI, normal in TACO. Chest x-ray, bilateral prehilar nodular shadowing, or these are radiological findings. Then echocardiogram is normal in TRALI, it's abnormal with TACO. Pulmonary artery wedge pressure is normal in TRALI, it's elevated in TACO. So blood counts, there is a fall in neutrophil and monocyte followed by neutrophil leukocytosis because of the reaction that involves neutrophils. Initial reduction, okay, and then the bone cells are triggered off to also produce, because the reduction in peripheral counts also stimulates the cells, the bone marrow cells, to release more cells into the peripheral blood system. But for the TACO, there are no specific changes. Fluid challenge for TRALI improves, worsens for TACO. Response to diuretics worsens for TRALI but improves the condition for TACO. Thank you. So with this, we come to the end of acute hemolytic transfusion reaction. Next time, we would consider other types of transfusion reactions. Thank you.